a second-year resident at CAMC, and he'll be introducing our speakers today.
So it's 8 o'clock on the nose, so I'm going to start. Ashley? Should we begin? Yes. Hi, good morning, everyone. Thank you so much. Whoa. Didn't know it was so electric today. Must have been that coffee. But anyway, thank you so much for coming in today. And it's really wonderful to be here in West Virginia. And we will be giving you this presentation titled Initiating Basal Insulin, Moving from Hesitancy to Action. So for the most part, this program is supported by an educational grant through Novo Nordisk and also has been accredited by the aforementioned agencies, as you see in the slides listed below. And this presentation will be eligible for a variety of CME credits depending on who it is that you're going to be subscribing or submitting to. So for the most part, everything here that you're going to be talking about, we're going to be speaking about is basically insulin. It's going to be about the basic science of insulin, how to use insulin, and any off-label discussion will be discussed accordingly. But I don't think that there's going to be any off-label discussion because the new long-acting insulins don't have an FDA label yet. So
Yes.
that's okay. So anyway, there is this Slido type of a program that we're going to be utilizing in order to submit questions. So for the most part, at your stations, there are QR codes. For those of you that will be seeing virtually, the QR code will present itself at the appropriate time. The questions will be asked. But for those of you that do see this QR code, please scan the QR code. It'll take you to the Slido site. This way you can participate in some of these CME questions. So my name is Javier Morales. I'm actually an internist. I practice in Long Island, New York, but I do have some teaching responsibilities at the Hofstra Northwell School of Medicine and am in private practice, just like all of you, taking care of a variety of medical illnesses, including diabetes and obesity and so on and so forth. And I'm actually delighted to be joined today by Seth Kramer, and he hails from the Department of Family Medicine over in Aurora, Colorado. So these are disclosures for the parties that were involved in developing this program and for the people that also helped to develop the program as well, which is our corporate sponsor. And now this brings us to the first portion of the presentation, and which is the discussion of the learning objectives. So for the most part, we have several learning objectives that I hope to cover today, we hope to cover today actually, and that is identification of how overcoming delays to insulin initiation can help to improve outcomes in patients with type 2 diabetes. But we also do have another learning objective, and that is the differentiation of the current and emerging basal insulin therapies and how they can have a beneficial impact on the concept of therapeutic inertia that we're all pretty much familiar with. So the first portion of the presentation is really spotting the whys of delays in initiation of therapy and moving past it. How do we address this therapeutic inertia for patients on basal insulin with type 2 diabetes? So when it comes to therapeutic inertia, we know that there is a myriad of reasons why this is being exercised. For the most part, there might be some misconceptions and misperceptions on the part of the patients that do suffer with type 2 diabetes. And when we look at the clinician sometimes may have some inertia or some apprehension about intensification of therapy, and that could be for a variety of reasons why. Healthcare systems oftentimes can provide roadblocks towards adaptation of therapeutic options that we know would be beneficial. And of course, there's always going to be the elephant of the room, which is going to be the expense. Even though these newer therapies that may be available could be a little bit costly, I think the payers need to realize that the outcomes oftentimes will be beneficial and basically are probably more important than the expense. So what about hemoglobin A1C targets? So for the most part, we have two large-scale agencies that do give a little bit of guidance in terms of how we should manage our patients. That's the American Diabetes Association and the American Association of Clinical Endocrinology. Now, even though ADA recommends a hemoglobin A1C target of less than 7%, whereas ACE would like to see less than or equal to 6.5%, there's more similarities to differences between both of these agencies. And that is, for the most part, try to normalize blood glucose as best as you can and safely without creating harm. And also taking into consideration the possible end organ benefits of certain therapeutic interventions that could be implemented for our patients with type 2 diabetes. The other thing that's also very important that they see eye to eye on is the recognition that intensification of therapy for diabetes may lead to some weight gain. And I know that it's been a very hot topic of recent, but we also need to remember that, if we can achieve good glycemic target with a beneficial effect on weight, we know that that weight benefit would impact favorably many different aspects of patient care and cardiovascular risk. So for the most part, individualization of target also needs to be exercised. So if you're young, if you have a long life expectancy, if you have no comorbidities, there's no reason where we can try to achieve normalization of blood glucose, especially with some of these new therapeutic interventions that have emerged over the years. However, if you are frail, older, maybe you have multiple coronary risk factors and events, and cancer, then maybe perhaps a more relaxed target would be the appropriate approach. So what about hemoglobin A1C targets? For the most part here, we're looking at data from the National Health and Nutrition Education Survey, or NHANES. And on the left-hand side of the slide, we're looking at two groups of people that have been treated with insulin. One of them with multiple daily therapeutic injections or multiple intervention, and the other one is just basal insulin. And as you could see, when we're looking at the earlier years, a relatively small percentage of patients were able to achieve the ADA recommended target of less than 7%. It's only until the later years that we see there, between 2015 and 2020, where we saw a significant improvement, particularly in those patients who were using basal insulin therapies. But when we're looking at individualized targets, as mentioned before, on the right-hand side of the slide, how many of those people are actually achieving their individualized targets? And we could see that once again, it tends to fall short between those that are on multiple daily injections, including those that are on basal insulin therapy. So even though we have therapies that we can introduce, including basal insulin in these cohorts of patients, why is it that we're not getting to that hemoglobin A1C target? And this is possibly related to therapeutic inertia, because as we do know, the initiation of insulin needs to be followed with appropriate titration, right? So how many people do you see in your clinical practice that get started on a basal insulin and that needle never moves? It's always going to be the same dose.
It takes a while to change that dosing. That's correct. And, we find that then we have a hard time getting our patients back. You could be 2-3 months before we come back. Maybe they weren't taking it as we were dosing it, and so we're back to ground zero again.
Oh, yeah. So for that reason, I think it's really important to remember that the patient needs to be educated about initiation of insulin and appropriate titration, but also the fact that there's multiple players that are involved in the care of that patient, and these people could be instrumental in terms of making sure that the patients use their insulins accordingly. Yeah. And what we've learned, well, as you will hear from Seth's presentation, is the fact that because these insulins are more predictable in their level of activity, then we could basically turn over the insulin titration to the patient successfully with self-titration algorithms. In fact, actually, we'll chat about that. That's an interesting point. Yeah. So, obviously, support is going to be required, and it's going to be multiple interventions that will be fruitful in terms of allowing our patients to get to where they need to be. So let's talk a little bit about basal insulin here, because who needs basal insulin? So for the most part, if your hemoglobin A1C is not at target and you're on multiple injections or multiple medications, then perhaps the initiation of insulin would be appropriate. When we're looking at the guidance that's provided by the American Diabetes Association, they recommend initiating insulin, particularly if your hemoglobin A1C may be greater than 10%, or if your blood glucose is running consistently above 300. It makes a lot of sense. But even more so if you have evidence of glucotoxicity, which is the polyuria, polydipsia, and the unexplained and unexpected weight loss. So these are real reasons why we should be thinking about insulin a little bit sooner rather than later. So this was a very interesting study as a historic study, a very important study for me, actually. This was called the 4T study. And what they did was they looked at patients that were on oral hypoglycemic agents, and they randomized them to start either prandial insulin, basal insulin, or premixed insulin analog. And what was really interesting here is that in those patients that were initiated with prandial insulin first, they wound up getting to hemoglobin A1C target a little bit faster. But there was an expense. And the expense was that there was more weight gain and greater hypoglycemia in those patients that were started with prandial insulin first instead of the basal insulin. So basically, the outcome of this trial was, and probably the preface in terms of why we're start with basal insulin, is that even though it takes a little bit longer to possibly get to hemoglobin A1C target, you're more likely to achieve that hemoglobin A1C target safer with fewer hypoglycemic events. So let's talk a little bit about basal insulin and type 2 diabetes, because this is data looking at over 22 studies conducted over a 10-year period of time in terms of when insulin is actually initiated. And we could see that for the most part, we as clinicians are waiting for hemoglobin A1Cs of between 8.7 to 9.8% before initiating any kind of basal insulin. And the median time is about maybe 5.25 years, with 71% of these patients not initiating insulin until the hemoglobin A1C was noted to be elevated on at least 2 occasions. So this is problematic because for the most part, hemoglobin A1C is usually assessed every 3 months because it's based on the lifespan of the red blood cell. Second thing is access to care, because even though we would like our patients to come back in 3 months to get their hemoglobin A1C reassessed, the reality is that not everybody may have that luxury or that capability of being able to see their clinician within such a timely factor. So for the most part, earlier initiation really should be exercised, and this might be one of these drivers of clinical inertia. So let's take a look in a little bit more detail at some of these other studies on the right-hand side of the slide, because in a 2023 more recent study, as little as 25% of patients using basal insulins did achieve their glycemic goals, which means that they were starting the insulin, as we had mentioned before, but they probably were not titrating accordingly to the appropriate fasting plasma glucose target. And remember, that fasting plasma glucose target could be individualized based on the need of the patient. In my clinical practice, I always shoot for a fasting of about maybe 100, 110. What do you do?
Yeah, it depends on the patient, but about 80 to 130, and then we kind of shoot around under about 100 to 110.
Yeah, and the ADA does recommend between 80 and 130 for the most part. But looking at 2016, only about 18% of patients discontinued basal insulin within a year of initiation. So this could be because of maybe psychological issues, maybe frustration over their care, or maybe even other factors that we've really not explored. But in 2016, 62% of patients initiated on basal insulin had their therapy interrupted for whatever reason. It could have been a surgical procedure. Maybe they went on vacation. They decided not to take their insulin. They just never restarted it again. And about 25% of patients in 2010 never refilled their prescriptions. So this is something that we really need to take into consideration and keep in the back of our minds. Now remember, I think it's really important that patients really need to be treated towards their goals, because we've learned that good glycemic control over a longer period of time will lead to a beneficial effect in terms of cardiovascular outcomes, what we call as a positive legacy effect. And we saw this clearly defined in the UK PDS study. So achieving good glycemic control and maintaining that glycemic control for a longer period of time is beneficial. But I think, and it's not listed here on the slide, is that there is a negative legacy effect that does exist, and that's for every 1% of hemoglobin A1C elevation, there's an increase in cardiovascular events by about in excess of 60%. So tight glycemic control is going to be really important. So what are some of these barriers that exist when it comes to insulin initiation in patients with type 2 diabetes? On the healthcare professional side, we could see that there is the perception of patient resistance. The patient doesn't want to be on insulin. There's doubts that exist in our minds about whether or not the patients are going to actually take the insulin as we prescribe. Sometimes we've not used insulin and are unfamiliar with using insulin. So we have to get a little bit more confident with initiation and titration. And then inadequate monitoring, because patients with type 2 diabetes really should be assessing their blood glucoses, especially if you're on basal insulin, because that is the stick that you're using to measure how to best titrate that insulin. And basal insulin really needs only one finger stick per day, depending on the generation of insulin that you're using, but maybe even fewer, as you will hear later on during the presentation today. And of course, as mentioned earlier, several slides back, some of our concerns do include the possibilities of hypoglycemia as well as weight gain. Now, what about on the patient side? This is the part where we really need to be very sensitive about, and that is that patients oftentimes view insulin as the final resort or personal failure. They're not unable to achieve appropriate glycemic targets. Just like us, they also are concerned about the potentials of hypoglycemia and long-term adverse events, and even they get a little bit shy if they're going to take insulin, if they're going out to dinner or at a public event. And I think that the fear of needles has significantly been reduced now because we do have smaller needles that are virtually painless with injection. And oftentimes in my clinical practice, when I'm starting injectable therapy, I will break that injection barrier in the office. I think one of the drivers that make injection initiation so much easier is how important the incretin class of agents have been towards managing our patients with diabetes, and how they really have become the forefront because of their multiple modalities of therapy. And convenience factor is also a major player here, and that is being consistent in terms of time of administration, particularly with the older insulin preparations, but not with the newer ones. So what are some of these obstacles towards insulin therapy in patients that could be contributing towards adherence? So here we look at the study in patients who are newly prescribed insulin. It's a little complicated, but in those who are newly prescribed, on the right-hand side of the slide are people who actually started their insulin, and on the left-hand side of the slide, those who never started their insulin and the reasons why. And I want to call your attention to the last two lines there, because these are really, really quite important. As you could see here on the slide, you could see that the risks and benefits were not well explained by the healthcare professional. So that being the case, I know we're all limited in terms of time when it comes to managing multiple disease states for our patients, but this is what the patients are actually saying about us. So even though we're trying very, very hard to get our patients to goal, I think we really need to emphasize and explain to them the true benefits of utilizing this agent. Sometimes if you're thinking about initiating insulin therapy, bringing them back and spending a tremendous amount of time dedicated towards insulin therapy might be the appropriate thing to do, particularly with those who may have some health literacy challenges. So, and that's what we see here at the bottom of the slide, is that sometimes patients really don't get it. They don't understand the disease state and what the impact of diabetes actually has. So how do we address some of these barriers towards basal initiation? Through communication and collaboration. For the most part, upon that diagnosis and whenever hemoglobin A1C is at or above goal, we need to discuss that progressive nature of progressive beta cell failure and how insulin replacement therapy will be instrumental. Now, there are some concerns that do exist concerning side effects and injectable therapies, which really we need to dispel some of these myths, and especially overcoming the sensation of the guilt that the patient may feel when it comes towards initiation of insulin therapy. Now, I think it's also helpful to anchor their treatment to a daily activity. So if they're going to dose their insulin at night, have them give it before they go to bed or before they go to the bathroom, or maybe even in the morning upon awakening, just like we do with many other medications. Now, because the pharmacokinetics and the pharmacodynamics of these insulin preparations are so good, nowadays we can empower the patients to basically control their own insulin and up-titrate or down-titrate accordingly. So just as an FYI, we'll talk a little bit about this later, is that pharmacokinetics is measurable levels of molecule within the bloodstream, and pharmacodynamics is actually what that molecule is doing. So these newer insulin preparations, as you will hear, do have improved pharmacodynamics with lower variability, which makes these insulins much more predictable and makes it a little bit easier for self-empowerment, which is important. And oftentimes when we do empower our patients with insulin therapies, they're more likely to achieve hemoglobin A1C target and remain adherent to appropriate therapies. So providing feedback based on glucose testing results winds up being really, really important, and we need to celebrate the victories that the patients actually experience. So what about waiting before insulin initiation therapy? So when we're looking at the left-hand side of this slide, we can see that 75% of participants with baseline hemoglobin A1C of less than 8% were successfully able to achieve a hemoglobin A1C of less than 7% when basal insulin was added to oral therapy. But when we're looking more specifically at hemoglobin A1Cs at insulin initiation, we could see that initiating basal insulin with a lower hemoglobin A1C led to a greater number of patients experiencing or achieving that hemoglobin A1C target of less than 7%, which is great. However, when we're looking at the right-hand side of the slide, the longer that we wait and the higher the hemoglobin A1C with initiation of insulin, the more weight gain that was experienced. So the take-home point of this study is don't wait until higher hemoglobin A1Cs for initiation of insulin, but rather, if you're thinking about it and the hemoglobin A1C is lower, then you're more likely to achieve success with less weight gain. So let's talk about a patient case here. This is JD. 58-year-old male, 12-year history of type 2 diabetes, along with coronary disease, hypertension, and dyslipidemia. So currently he's on losartan, 100 milligrams per day. He's on 10 milligrams of rosuvastatin, metformin, 1 gram twice a day for over a decade. And he's on the SGLT2 inhibitor, dapagliflozin. Now, he's been started on semaglutide, 1 milligram weekly about 6 months ago when his hemoglobin A1C was 10.4%. So at today's follow-up, his hemoglobin A1C was 8.1% with a fasting glucose of about 190. Postprandial glucose are consistently above 220. His BMI is 35.1. His GFR is at 75 mLs. So even though his GFR is 75, that doesn't mean that he doesn't have diabetic kidney disease. Because one of the things that we really should be doing that we're not doing enough of is checking that urine albumin to creatinine ratio. And oftentimes the UACR will be abnormal before there's a decrease in the glomerular filtration. And it winds up being really important because there are things that we can do to reduce that risk of progression of chronic kidney disease related to diabetes. And we do have pillars of therapy that have been well established. And I'm happy to say that looking at the medical therapies that JD is on has been helpful in terms of curtailing the progressive nature of chronic kidney disease, but there's still one medical therapy that could be added on, but it is out of the scope of today's talk. So, for the most part, going back to JD, and also very important is the fact that the kidneys do play a big role in terms of cardiovascular outcomes. But JD has lost about 20 pounds since his last visit about 6 months ago. He reports checking his blood glucose twice daily for most days. So we're going to have our first ARS question. So please break out your devices. So during the visit, you engage in a shared decision-making conversation with JD. So what's the next appropriate topic to discuss to improve overall glycemic control in this patient? Should we follow up a scheduled visit in 3 months to check his hemoglobin A1C again? Do we emphasize the importance of lifestyle intervention and also consistent monitoring of blood glucose? Do we discuss the benefit of basal insulin of when the hemoglobin A1C remains above the goal? Or do we discuss the benefit of full physiologic replacement when postprandial readings are elevated at goal? So please take a couple of moments and select. So, what's really interesting, Seth, is that it's so much more than just glycemic control. And I think the ADA really has it down pretty well in terms of targeting some of these comorbidities that the patients actually may fall into.
Yeah. So and I think we're missing some of those comorbidities as we're managing our patients. We're focused on just the
glucose-centric approach, which is not good.
And there's other things. Yep.
Yeah. So let's take a look here. Do we have any results on the? I have to walk out because I really can't see the results.
We have 17.
Yeah.
People here.
And will the results be reported? Okay. So we're going to continue on with the presentation for the. Oh, there we go.
Yep. The benefit of basal insulin when A1C remains above goal.
Yeah, and I think that when it's above goal, it certainly makes a lot of sense. I thank you for listening to the presentation. So it's great. Anyway, I'm going to turn it over to Seth now. I want to thank you for listening to my preamble to this presentation. Take it away.
Excellent. So we're going to delve into some of the next generations and the changes that we're seeing advance from where we saw things over 100 years ago, and things have changed since then. We first saw the there we go. Yeah, we first saw the initial isolation of insulin back in the 1920s. Moving on to our first synthetic insulin in the 70s, and then through seeing rapid action and long-acting insulins, and now we're at the advent of these ultra-long acting insulins. So we've got a number of basal insulins that we've used. And so, it kind of starts with, and I think the important thing to see here is that the kind of advancement in how this longer duration of action has occurred in some of them. We've had NPH, that, we have used. It was one of the more initial ones, but it's the way that it kind of deposits, and we use it is a twice a day insulin. So it's not lasting as long through the whole day, about 8 to 12 hours, requiring multiple doses in the day. There's some increased risk for hypoglycemia when we use this over some of our other ones that we have. Advancing to what we have now, glargine U100, getting us to about 22 to 24 hours, and that slowly advances when you use it in the sub-Q to depositing over a bit more time in the sub-Q tissue to get us to more of a day. What about glargine and degludec?
Yeah, so it's kind of interesting when you look at these insulin preparations, the evolution of the development of insulin. So analogs. Analogs is nothing more than taking a native molecule that's produced by the body and altering a couple of amino acids in order to, again, have an effect on the pharmacokinetics and pharmacodynamics. So when we look at some of these older generation basal insulins, how many of you, show of hands in the audience, remember Lente and Ultra Lente? Oh, yeah. Boy, yeah. So it was really, really interesting because there was a fair amount of hypoglycemia that existed because of what we call the stacking effect, where you have the effect of one insulin And then you give the next injection, and then it stacks up on the already existing injection, and the possibilities of hypoglycemia is significantly increased. So by altering some of these things, we can basically predict more readily the duration of action of these insulins. So the first generation basal insulin, which was basically insulin glargine and insulin detamir, did have a 24-hour duration of action, but for the most part was dose dependent. So the lower the dose, you were a little bit less likely to get a full 24-hour duration of action. Higher doses were able to achieve it. But mechanisms of protraction continued to evolve. And what they learned with glargine is the fact that if you concentrated glargine, same amount of insulin in 1/3 the volume, then the dissipation of the insulin would be over a longer period of time and at a flatter profile, which was kind of interesting. So this was one of the proposed ways of prolonging the activity of the insulin. Insulin degludec's a little bit different, however, and they use certain lessons from years gone by with some of their other insulin product, and that was the blessing of the fatty acid chain. Because to that insulin was an 18-carbon fatty acid chain, which allowed the insulin to basically bind to albumin. So now you have an affinity to albumin, so it wound up being more homogeneously distributed, but also the mechanism of how the medication deposits subcutaneously, because it exists as dihexameric states following injection. And then on the basis of the pH in the tissue, then what happens is that these dihexamers would then dissipate into insulin monomers and then release into the circulation. So insulin degludec winds up having, as a consequence, a 42-hour duration of action, and insulin glargine U300 with a 36-hour duration of action. But what was even more beautiful about these molecules is that there's no stacking effect because it remains in the subcutis, so it's not in the circulation. And the other thing was it offered the flexibility of dosing one time per day, and it didn't matter what time of day you were able to dose the medication. More forgiving.
Yeah, you know, I mean, that makes a point on dosing some of these, because you have to, with NPH, be a little more precise in terms of timing. And when you get towards degludec and some of these more prolonged insulins, you know, you don't have to be as precise in terms of the timing of day. They can be off and still see no decrease in or increase in hypoglycemia and get the insulin that they need. And so, and that's an important point as on degludec as we kind of advance to some of these more longer acting analogs that we have now. We're at the advent of weekly basal insulin. And if we also remember with our GLP-1 agonist medications, you know, they started with daily administration, and you had to administer that ongoing through the week, and then advanced to what we have now of weekly options. And so we're moving in that direction in terms of insulin administration as well. You know, and he alluded to some of that effect of that prolong and the half-life of some of these weekly insulins that we have now. Two that we have now, insulin icodec and insulin efsitora alpha, which we'll go into here more specifically.
Also, what's really nice to know is the fact that the within-day variability of these insulin preparations have gotten significantly better. So it is more predictable from injection to injection that the level of activity will be there. So that lower coefficient of variation, so to speak, ultimately translates into fewer hypoglycemic events and more predictability, which allows the patient to become empowered and makes us feel more comfortable empowering those patients.
Yeah, and I think with the increase the variability effect, you know, comparable hypoglycemia risk to our daily basal insulins, and you know, just reducing the burden again from daily injections at the beginning, having to time those injections, having to, when you're out, you know, having to go off and provide those injections that you have, to a weekly option where there's not so much that you have to be so precise on the timing of the actual administration within that week itself.
And by the way, should you have any questions during today's presentation, please, we encourage you to log them into the Slido so that we can address them at the conclusion of the presentation.
So there's some robust data coming out and advancing in the weekly options here. Efsitora, icodec leads the way with 6 phase 3 trials that have gone through or are working. Those are the onwards trials, which we'll get into in a little more detail. And then Efsitora and icosema. Icosema being icodec and semaglutide combined as a combination. So this is an interesting, so we talked about degludec. You know, this is an interesting Efsitora weekly analog. And what's unique about this and how it works to bring that prolonged duration of up to 17 days of a half-life is this FC region that we see. And the FC region is that tail end of an antibody, IgG antibody that we see here, and that's attached to these modified insulin analogs. It's this FC region that allows us to decrease the clearance of the molecule and the breakdown of the molecule itself so that it lasts for the 17 days half-life and that weekly dosing that we get.
It's not the first time we've seen this type of technology utilized. In fact, this was adapted from dulaglutide. Because if you look at dulaglutide's structure, it's exactly the same thing. It's basically the FC portion with the GLP-1s attached to each FC heavy chain. So
everything builds on everything.
Yeah.
You know, we see advancement. So, you know, we continue to use what we've learned from others and adapt and expand upon it. So the Quint trials. These were the trials that looked at Efsitora. There's a 5th trial, Quint 5. You don't see here. That was for type 1 diabetes. 1 through 4 here were for type 2 diabetes, running the gamut of variable patients. So those who were insulin naive to those who were on basal or basal bolus already, and a combination of those. They looked at a comparison to insulin glargine and insulin degludec to Efsitora. And so looking directly at the Efsitora 2 trial that compared it to degludec, there was a comparable decrease in the A1C at 1.26% in Efsitora. There was no significant difference between them that they experienced. There was no significant difference in the hypoglycemia rates between the two of these. There was a little bit of hypoglycemia noted, about 6 episodes in the study. They were all in the degludec group. And in fact, probably not necessarily to the degludec insulin itself, but 5 of those episodes were also on sulfonylureas. So you can imagine that we know when you have sulfonylureas, glipizide and glyburide are examples of that, in conjunction with insulin, that may likely raise your risk for hypoglycemia, and probably what instigated what we saw in that group. The safety profile was comparable. Significant adverse events were not significantly increased in both groups, but there was no difference between them. There was a small increase in just mild injection site reactions. And then body weight. You know, we talk about body weight, with all insulin, and we might expect to see body weight go up. And we, of course, saw that with both of these. But I think what the important part here is that there was no difference between the body weight increase.
Yeah, I think this really instilled confidence in terms of being able to use a weekly insulin instead of a daily insulin. So, I mean, the benefits are tremendous because you're decreasing injection burden on the patient and perhaps maybe increasing adherence.
Right. Moving on to Isodec, the other weekly insulin. Isodec has a totally different structure and mechanism to getting to the long duration that it has. And how it does that kind of gets back to what you were mentioning with some of the other insulins, this long fatty chain acid.
And the longer the fatty acid chain, the greater the affinity for albumin. So how do you make a weekly insulin? So for the most part, you have to kind of have a good control in terms of the appearance of the insulin in the circulation. But the other thing is you want to decrease insulin receptor sensitivity. And that's basically what we saw with Icodec. So we had a longer fatty acid chain, so we have a greater albumin affinity, less receptor affinity at the level of the insulin receptor. Now you have a great protracted mechanism of action that allows the insulin to be used once per week.
We also have these amino acids that are attached, and then so combined we get this whole same duration, prolonged duration, once weekly, half-life about 196 hours. So 7 to 8 days. I mean, we get a good long duration that's not going to, just spike up and then drop down and cause hypoglycemia like you might see in that initial NPH or some of those insulins, and especially what we see in our fast-acting insulins. It was the Onwards trials that looked at Icodec. Again, there's a sixth trial that you don't see here that was in type 1 diabetes. So these 5 looked at that. Very similar look as the Quint trials did for the other, and they looked at insulin-naive patients and comparing them to glargine and degludec, and then those on bolus or basal or combination with Icodec. And then, to point out Onwards 5. Onwards 5 was really interesting because it wasn't so much looking at maybe the type of insulin, but using this dosing app guide and something that you mentioned before, in engaging the participants in the study to dose their insulin. And they had the opportunity to, based on the recommendations, do their insulin titration and then have the physicians intervene if they needed to or manually change that. But it really engaged the patients to dose their self-dose through that, their insulin.
And you know what was very interesting is they only needed 2 insulin values per week in order to do it because of the long protraction. So even finger stick monitoring decreases when you're on a basal insulin that's once weekly. Because you're only adjusting it every week. You're not adjusting it every 3 days or so.
They're using, so typically what we do with basal insulin is that we use our fasting glucose and we get their fasting glucoses to try and make an adjustment. Oftentimes it's taking, sometimes months to get them back in to do that, but we try to do that. With this, we're using 2 to 3 of our fasting glucose measures of that last week to make that recommendation into the next week. And it's just happening once a week, if not. The Icodec Onwards trial looking at A1C and Icodec either matched or slightly had a higher A1C drop of 1.6%. And you'll notice that was in the Onwards 5 trial where the participants were self-dosing through this app. The incidence of severe hypoglycemia was quite low. Among both groups, we would expect to see that. There was no significant difference between them either. And, I think the outlier here you might notice is that in this Onwards 4 trial, which looked at glargine with Icodec, there was a significant rise in that hypoglycemia. Not a significant difference, but a rise in both of them. What I think the point to make here is that this was the group that was added with the basal bolus insulin. And so they had bolus insulin added along with icodec or with glargine. And so I think that increased insulin exposure may have contributed to why we saw a higher rate of hypoglycemia overall than in the other groups.
Yeah, it's more difficult to control someone on full physiologic replacement. And there was a fair amount of prandial-related hypoglycemia because there were 2 active titrations that were going on. What we didn't talk about, and we really didn't show in the presentation, was that there was a study where patients were purposely overdosed. They were given double the dose or 3 times the dose of a weekly basal insulin to see what happens. And surprisingly, there was really not much hypoglycemia that was seen. And part of the reason why is because of the augmentation of the protective mechanisms. So there was an increase in norepinephrine release, epinephrine, and cortisol release. So that offered a little bit of protection. So that was pretty interesting.
Covered them. Yeah, you're right. Body weight. We talk about body weight and increase in weight. We saw that again in this instance. Comparable to every other studies that we've seen in the others. Slight difference in the Onwards 2 trial, which compared it to degludec, and in fact there was apparently a slight decrease in degludec weight there as compared to icodec, but otherwise most of them comparable, and these are in kilograms in weight change. So about 2 to 3 kilogram weight change comparable across both groups. So as we're advancing to weekly insulin, we have to talk about that the dosing and considerations of titration is different than what we're used to with the daily basal insulins. And so when we talk about the weekly insulins, and because of the slow, steady state rate that we get with these weekly insulins, to get it up faster, it may require having a initial loading dose to give. And that's what they did in the Onwards 2 trial and 4 trials for degludec, where they did a 50% increase in the dosing on that first injection for the week, and then went on to a titration plan. And then on the QUINT 2, 3, and 4 trials, they had a 3 times the loading dose of about 300 units on that first weekly dose, and then went on. So efsitora then continued after that to have it titrated from a loading dose and starting back down at 100 units, and then incrementally over on a weekly basis increased about 20 to 40 units based on target. Target was 80 to 130 of the previous 3 fasting glucose readings that they got from that previous week. And then they increased that up. You can imagine that happened weekly for 12 weeks and then went on to a monthly titration check-in assessment and titration. But that may not be comparable for someone in primary care to be titrating this every week, and looking at the glucoses, titrating it, and staying engaged with patients. That's going to be hard in the setting of a clinic. And so on the QUINT 1 trial, they in fact actually had fixed dosing. So fixed dosing meaning that they started with 100 units, and they stayed on that for 4 weeks, and then based on target of 80 to 130 and the previous 3 fasting glucose, they increased that to 150, 250, and 400 every 4 weeks. And so it was a monthly increase of the dosing of that. There was about 4 doses from 100 to 400 that increased over a month. So you can imagine that it's a much simpler fixed dosing. It did take longer to get patients to target that we talked about, 80 to 130, but much simpler and probably easier to do. For those that were above 400 units, now when we say 100 units to 400 units, it is 1-to-1. And so you can, if you broke that down, it would be about 14 units per day, kind of similar to what you would see in a daily basal insulin to start, 100 units, and then kind of on up comparably for the daily dosing. I might add also that 50% of those patients in the Quint trial on Efsitora were on GLP-1s as well. Okay, so and they did not see increased hypoglycemia when they were on both GLP-1 agonist medication and a weekly insulin there too. Well, now you come to actually combining them. IcoSema, which is in the combined trial, looked at icodec with semaglutide, and interestingly enough, they saw a decrease of about 0.44% in the A1C in the IcoSema group compared to semaglutide alone. It was the comparable group. No significant increase in hypoglycemia when you did that. Safety profile was excellent. You did, with no surprise, see an increased weight loss in the semaglutide group alone, but the increase in weight for the combination was about 0.84 kilograms, and so in the IcoSema group, and so you can imagine that probably the semaglutide mitigated a good portion of the weight gain that you might see in the insulin use itself. There was an attempt to make oral insulin. How great would it be to maybe use oral insulin for those that are quite hesitant at injection still or starting insulin in itself? And this was a long-acting development of insulin itself, and unfortunately, it required very high doses to just manage the blood glucose. And so this was actually discontinued, and they discontinued the study, and that was not further developed. So we do not have this available to us. Do we have a...
That's right, it's an ARS
question
question.
there?
Yeah, it's an ARS question.
So we have a next development in in JD's visit here. So we have he started basal insulin in his fasting glucose is 106. His A1C improved, does remain above goal at 7.4%. What would be your recommendation to JD in your shared decision making as you sit there with him? Make no changes and just emphasize adhering to what he's on already, the need for continued therapy intensification of what he's on to reach goal, to test his blood sugar once a day rather than twice daily, or do you just schedule a follow-up 6 months after and see how he's doing? Okay, good.
So what do you think?
I'm not going to give my
No,
my
we're not
answer
going to
yet,
give
but
our answers. Let the audience decide. But certainly his A1C is 7.4%.
I will say that this actually comes, I see this often where, patients will come in, maybe their glucose is looking good, their fasting glucose is looking good, but their A1C is still up a little bit more. And so there's almost like a little discordant there in terms of, what do you do with that?
Lifestyle intervention. You can't go wrong with lifestyle intervention. Click one more time. Can't go wrong with lifestyle intervention because what we learned in the Look Ahead study was there was significant improvement in insulin sensitivity and reduction in hemoglobin A1C with people who did practice aggressive lifestyle intervention. So it should always be emphasized. But nonetheless,
what do we see?
I think the need for continued therapy intensification to reach goal was the most popular answer, which I agree with. I think we need to avoid that clinical inertia and move forward.
And I think one of the quick points here is that we may be seeing with this A1C up that the Mealtime or postprandial blood sugars are up still, even though the fasting is down at 106. And so sugars may be going up in the middle of the day with that and bringing that A1C up, needing to intensify a little bit more. After addition of therapy intensification, JD calls the office to ask about his frequent unpredictable glycemic fluctuations. Which advanced technology would you provide real-time data to help fine-tune his diabetes management? Hybrid loop, insulin pump, a bio-wearable continuous monitor for glucose and ketones, continuous glucose monitor with trend analysis, or traditional ketone monitor for periodic testing. Take a quick second to answer that.
How about a dog?
Yeah. Well,
Isn't that interesting? You have dogs that detect hypoglycemia.
Yeah, detect a lot of stuff.
Yeah, which I think is kind of interesting. But I think
Do you have a response on those?
click one more time. No, on your thing.
Yep.
Okay.
Very good.
I think nowadays,
Continuous glucose monitor.
yeah, CGMs really have reshaped what we're doing now in terms of diabetes, because now for the first time, we're able to actually look not just at the percentage of the time that a patient is within a certain range,
Yeah.
but also but also looking at the variability, which is the next factor when it comes towards managing our patients with type 2 diabetes. So speaking about technologies, so of course we have these insulin pumps nowadays that we use for a lot of our patients, and it's great because it delivers that blood glucose. But now we have these closed loop systems. Tell us a little bit about the closed loop.
These closed loop systems are quite unique, and they're developing to the point where they will read the CGM, continuous glucose monitors, to get the blood sugar and start adapting the insulin. The insulin's getting released like every 5 minutes or more throughout the day instead of once a day or once a week. And so it can fine-tune that and over time learn from previous uses of total daily use of the day and start increasing that as needed automatically.
And CGMs really have revolutionized everything. And nowadays, they're taking measurements every 5 minutes or so. They're recording your blood glucose. And some of these are actually safe to use in an MRI machine, which I think is kind of neat.
Yeah,
and we also
absolutely.
have an implantable CGM that has been under development. Of course, you got to change the sensor every couple of weeks, but they're really protracting it, which is kind of neat.
And a newer one lasting up to a year now.
Oh, yeah. Now, as I mentioned before in this presentation, the patient is not on this journey by themselves, and you're not the only person that's touching the lives of these patients. I think it's important to remember that the dietitian is there, the physical therapist is there, the pharmacist is there, and other specialties that could help to guide the management of our patients. So taking a team-based approach ultimately leads to the greatest success for our patients.
And I think we'll get to one of your questions, in terms of how do you dose and how do you get your patients back in and how do you do all this. I think it kind of gets back to this team-based care.
Yeah, so I think it's really important to individualize the patient. What are their goals? We need to be really smart about how to get our patients to where they need to be. We need to address this clinical inertia. We need to take latest evidence and implement these guidelines to drive home which medical therapies would be most appropriate for our patients, and if need be, use integration of technology for all of this. So I want to thank you all for joining us today. There is a virtual education hub that is available at CME Outfitters where you could see some of these presentations, including to others that have been delivered so far. Now, there is a QR code here. I'm going to leave that there for you to scan, so this way you can submit for your credits. But for the most part, we do have some questions that came in.
So let me, there's a lot of technologies such as CGM. They're expensive. They can be expensive. They can be unaffordable for some of our patients.
Well, it's as much as checking your finger stick 3 times a day if you're going to be a multiple tester.
Could you give us an answer to the technology question that reflects this situation?
Well, I think you have to look at risk-benefit ratio.
Yeah.
And for the most part, if it instills confidence on the part of the patient, that's actually kind of cool. And what's nice is that these have some alarms that will alert the patient in the event of a potential hypoglycemic event that can occur. So for that, it offers the patient some peace of mind as well as their caregivers and their family members.
If you're on insulin also and you're checking your finger stick quite a bit, it's pretty comparable to using a CGM cost to how many you're using in terms of the test strips, but also you might see some behavioral change with the patient using that in terms of how they're eating and how they're doing that as it associates with their insulin use. What role does patient comorbidity and frailty play in therapeutic inertia that you talked about, and how can clinicians kind of balance those?
Yeah, I mean, for the most part, tremendous amount. It offers a tremendous amount. Again, it's about individualization of target. So once we start to individualize, maybe a relaxed hemoglobin A1C target would be more appropriate for somebody who might be older with multiple comorbidities.
Yeah. Let's talk to the new insulin delivery methods that we have, like with the weekly. How do they come? Pumps, pens, interacting with kind of emerging formulations, and what are the synergistic benefits for patients?
I think we've really become a pen society.
Yeah.
So a lot of these weekly insulins will be coming in a pen delivery device, and when we're looking at needle size, I mean, it doesn't get any smaller than a 32 gauge, right? So I think pens are here to stay for a while.
Yeah, and we won't probably see this, likely in a pump, because the pumps are going to use short-acting insulin that's getting released so it can fine-tune and control that mechanism of action.
I think we have one that came in. How do emerging insulins address issues like hypoglycemia risk, and what role do these insulins play in reducing the burden of adverse events? So that's a great question. I'll answer that. Actually, we both answer that, because I think what's going on for the most part is that these newer insulins have greater predictability. So when we're looking at the pharmacodynamics, the level of the insulin, there's less within-day variability. And if there's less within-day variability, that translates into fewer hypoglycemic events. So that's part of the reason why we can empower our patients with self-titration.
And that's what we do often. We do that.
And
another one there? How
much
time do we have?
No, I think we're pretty much done. So listen, I want to thank you all for joining us this morning. We certainly do hope that you found the presentation enjoyable and educational. And we will be in the back for additional questions or comments if you have any. Thank you very much. Enjoy the rest of your day.
Thank you.